So we're here at the last video for chapter 19, dealing with the heart. Now we're going to move on to the cardiac output. So cardiac output, what is that? That's the amount of blood ejected by each ventricle in 1 minute. Now heart rate will determine, heart rate times stroke volume will give us heart rate. Will give us cardiac output. Now the body's total volume of blood is 4 to 6 liters per minute at rest, and it passes through the heart every minute. Now our cardiac output at 75 beats per minute times 70 milliliters per minute can give us approximately 5,250 milliliters. So if we had a heart rate of 75 beats per minute and a stroke volume of 70 milliliters per beat, we times that together, our 75 times our 75 times our 70, 75, come on. Okay, it's taking a long to load up. Alright, here we go. Our 75 times, let's do beats per minute, times our stroke volume, which is 70 milliliters per beat. It will give us a total volume of a stroke output of 5,250 milliliters per minute. So if I ask you, if I put something on a test, what is the stroke volume or what's the cardiac output of someone with a heart rate of 75 or 80 beats per minute and have a stroke volume of 70, then you will know you have to multiply. I'll choose the other one. But if I ask you what is the stroke volume, and I give you the cardiac output and the heart rate, what do you think you would do? You have cardiac output divided by our heart rate. That will give you our stroke volume. So the cardiac output is, just say it is 6,000, and the heart rate is 60. I'm just making up numbers right now just to do it quickly. Then what will be the heart rate? What will be the stroke volume? It will be 100. But don't forget our units. Stroke volume is, well, cardiac output is milliliters per minute, and our heart rate is beats per minute, and our stroke volume will be milliliters per beat. Okay? And the same thing if I asked you for the heart rate. The heart rate, come on, will be cardiac output divided by the stroke volume. Cardiac output divided by SV will give us our heart rate. Okay? Let's make sure you understand how to work that out, because you will see a calculation or two on your test. Something very minor. So you don't have to use calculator for. I'll try to keep it simple. Okay, so let me get this off of here. Alright, so now that we have an understanding of cardiac output and how to calculate our heart rate and our stroke volume, we have to know that cardiac output is going to vary with activity. So if the person is but taking part in vigorous exercise, that cardiac output is going to be a lot higher. And it may increase to about 21 liters per minute for a fit person. For a world-class athlete, we're looking at 35 liters per minute. Now the difference between maximum cardiac output and resting cardiac output is called cardiac reserve. So this is when a person is sitting down doing absolutely nothing. To be sitting down watching TV, can't say absolutely nothing, but sitting down just watching TV or reading a book or studying for my test, that will be your cardiac output. But then when you start exercising or you do a particular stress test or you take your heart to its maximum, when you subtract that maximum from your resting, that will give you your cardiac reserve. Now, cardiac output can be changed by alterations in heart rate or in stroke volume. These usually are somewhat interdependent and inversely related. So if your heart rate increases, your cardiac output would increase, should increase. But if the stroke volume increases, if the heart rate increases and the stroke volume decreases, then we know that with cardiac output, it will increase. No, actually, it will actually stay the same. I'm sorry. If the heart rate increases and the stroke volume decreases, then it will stay the same. If they both increase, then the cardiac output will increase. And if both of them decrease, then we know that it will decrease. Now, heart rate is most easily measured by taking a person's pulse or at point where an artery runs close to the surface. Heart rate can be obtained by counting the number of pulses in 15 seconds and multiply it by 4 to get beats per minute. In newborns, the resting heart rate is commonly 120 beats per minute or greater, and this declines to an average of 72 to 80 beats per minute in young adult females and 60 to 74 beats per minute in young adult males, and it rises again as you get older. Now, tachycardia. This is a persistent resting adult heart rate above 100 beats per minute. It can be caused by stress, anxiety, drugs, heart disease, or fever. Now, heart rate also rises to compensate for a drop in stroke volume. So the heart races when significant blood has been lost or the myocardium has been damaged. Now, bradycardia, it is persistent resting adult rate below 60 beats per minute. It is common during sleep and in endurance trained athletes. Hypothermia also slows the heart rate and may be deliberately induced for cardiac surgery. Now, diving mammals, they exhibit bradycardia during the dive, as do adults to some extent when the face is immersed in cold water. Now, factors that raise the heart rate are called positive chronotropic agents, and those that lower is called negative chronotropic agents. The autonomic nervous system can have chronotropic effects. The reticular formation of the medulla oblongata contains cardiac centers that initiate the autonomic output to the heart. Some neurons have a cardiostimulatory effect, and it transfers signals to the heart by way of the sympathetic pathways. Others have a inhibitory effect communicated by way of the vagus nerve. The sympathetic postganglionic fibers are adrenergic and release norepinephrine that binds to the beta adrenergic fibers in the heart. Now, binding activates the CAMP, which is our cyclic and adenosine monophosphate second messenger system in the cardiocytes and the nodal cells. Now, CAMP activates the phosphorylase that would open these calcium channels in the plasma membrane, allowing influx of calcium that activates depolarization of the SA node and contraction of the cardiocytes, so it speeds up the heart. In addition, the CAMP accelerates the uptake of the calcium by the SR, enabling the cardiocytes to relax more quickly. Now, adrenergic stimulation can raise the heart rate as much or as high as 230 beats per minute. Now, the limit is set by the refractory period of the SA node. Cardiac output will peak at a heart rate of 160 to 180 beats per minute, and at higher rates, the ventricles do not have sufficient time to fill before contraction. Our parasympathetic vagus nerves have cholinergic inhibitory effects on the SA and the AV nodes. Acetylcholine is going to bind to those receptors, the muscarinic receptors, and open the potassium ion channels in the nodal cells. Now, as potassium exits, the cells become hyperpolarized and fire less frequently, so the heart slows down. The vagus nerves have faster acting effects on the heart than the sympathetic nerves because the acetylcholine acts differently on the ion channels. Now, if all sympathetic and parasympathetic stimulation of the heart is blocked, or if the cardiac nerves are severed, the heart beats about 100 beats per minute. That's the intrinsic rate of the SA node. With intact innervation, the resting heart rate is held down to about 70 to 80 beats by vagal tone, the background firing rate of the vagus nerves. More extreme vagal stimulation can reduce the heart rate to as low as 20 to 20 beats per minute, or even stop it, or just briefly. Now, placing the heart rate under influence of the cardiac centers and the medulla allows input and integration of the stimuli into the heart rate. We have sensory and emotional stimuli that can increase heart rate and in anticipation of an event. So if you're getting ready for a race, you're anxious and you're ready to go, and that's where we have the sensory and emotional stimuli that's increasing your heart rate. Then you have emotions such as love and anger also affect your heart rate. Now, medulla also receives input from receptors in the muscles, joints, and arteries, and the brainstem. Now, proprioceptors in muscles and joints, they provide information on changes in physical activity, allowing the heart rate to increase even before the metabolic demands start to rise. We have baroreceptors. Okay. Don't know why it's doing that. We have these baroreceptors in the aorta and the internal carotid arteries. They send a continual stream of signals to the medulla, providing information on the heart rate and the blood pressure. to which the medulla responds by altering sympathetic output in a negative feedback loop. The chemical receptors in the aortic arch, well, you might remember where the aorta and the aortic arch are, and in the carotid arteries and the medulla, they provide information about blood pH, carbon dioxide and O2 levels. Also, we have hyperkalemia, which is an excess of carbon dioxide, and acidosis. They lead to an increase in heart rate, and hypoxemia, which is a deficiency of oxygen. It leads to a drop in our heart rate. Now, responses to fluctuations in blood chemistry and pressure are called chemoreflexors and baroreflexors. Yep, here it is on this page. Here we have our hyperkalemia and our acidosis, and we have our hypoxemia. And here's our chemoreflexors and our baroreflexors that are responses to fluctuations in blood chemistry as well as with pressure, and are both negative feedback loops. Now, chemicals also have chronotropic effects. The blood-borne epinephrine and norepinephrine, or catecholamines, from the adrenal medulla have the same effect as epinephrine from the sympathetic nerves. The chronotropic action of other chemicals is also related to their impact on the catecholamine CAMP mechanism. Now, nicotine, it accelerates the heart by stimulating the catecholamine secretion. Now, the thyroid hormone is going to stimulate the upregulation of the adrenal receptors. So the hypothyroidism commonly produces tachycardia. When dealing with caffeine and related stimulants in tea and chocolate, they inhibit the CAMP breakdown, prolonging adrenergic effects. Then we have the electrolyte with the greatest chronotropic effect is potassium. I'm sorry, I'm here chuckling because I'm about to eat a piece of chocolate. I'm thinking about the CAMP that's going to be inhibited. So with the electrolytes, we have hyperkalemia, which is excess of calcium ions that diffuses into the cardiocytes, and they keep the membrane voltage elevated, inhibiting the cardiocytes repolarization, and the heart rate becomes slow and irregular, and the heart may arrest in diastole. With hypokalemia, which is a deficiency of calcium ions, those ions are going to diffuse out of the cardiocytes, and they become hyperpolarized and harder to stimulate. Now, potassium imbalances are very dangerous and require immediate medical attention. Now, pertaining to calcium itself, we have hyperkalemia. I hope I pronounced those other two right, hyperkalemia and hypokalemia. If not, I'm sorry. But calcium, hyperkalemia, where you have an excess of calcium ions, and it causes a slow heart rate, whereas the hypokalemia is a deficiency in the calcium, and it will elevate your heart and the contraction strength. Now, they are rare, but when they do occur, the primary effect is on the contraction strength. Now, stroke volume, which we talked about earlier, is governed by three principles. We have preload, contractility, and afterload. Now, increases in the first two increase the stroke volume. So increases on preload and contractility will increase our stroke volume, whereas the afterload increases in afterload will reduce our stroke volume. Now, preload. Preload is the amount of tension. Wow, okay. Preload is the amount of tension in the ventricle myocardium immediately before it begins to contract. So right before it contracts, there's some tension in the myocardium, in the ventricles area, right by the myocardium, the ventricular myocardium, right before it starts to contract. So as the active muscles massage the veins, they drive more blood to the heart, which will increase that venous return. So increases in venous return stretches the myocardium, and because of the length tension relationship, moderate stretch enables the cardiocytes to generate more tension upon contraction. So we have more forceful contraction will expel or get rid of the blood. Now the Frank-Starling law of heart, it states that the SV, the stroke volume, is proportional, that's what this means, proportional to the EDV. Ventricles tend to eject as much blood as they receive. So if they don't receive a lot of blood, they're not going to eject a lot of blood. And this effect helps balance the output of the two ventricles. Contractility refers to how hard the myocardium contracts for a given preload. Factors that increase contractility are called positive inotropic agents, and those that reduce it are negative inotropic agents. Now, calcium has a strong positive inotropic effect, and it increases the strength of each contraction. This is calcium we're talking about. Now, in hyperkalemia, where we have an excess amount of calcium, those extra calciums are going to diffuse into the cardiocytes and produce strong prolonged contractions, and in extreme cases can cause cardiac arrest in systole. Now, in hypokalemia, where we have a very low amount of calcium ions, the cardiocytes are going to lose the calcium ions to the extracellular fluid, leading to a weak heartbeat and potential, let me see if it's on the right side, yep, and potentially to a cardiac arrest in diastole, and is more likely to kill through skeletal muscle paralysis. Now, as the agents that affect calcium also have inotropic effects. Let me go back, because this is looking at the negative inotropic, and we're still on positive. Now, agents that affect calcium also have inotropic effects as a result. We have the norepinephrine. Norepinephrine will increase the calcium levels, and this is still a catecholamine, and it increases not only the heart rate but also the contraction strength, as does the epinephrine. So those are catecholamines. Then we have our glucagon. Our glucagon exerts an inotropic effect by stimulating our CAMP production. Now, solution of glucagon and calcium chloride is sometimes used for emergency treatment of heart attacks. Now, digitalis, that's from a foxglove plant, and also raises the intracellular calcium level, and is used to treat congenital heart failure. Now, hyperkalemia has a negative inotropic effect because it reduces the strength of the myocardium action potential, and thus the release of calcium into the sarcoplasm. The vagus nerve has a negative inotropic effect on the atria, but no significant effect on the ventricles. Now, afterload is the blood pressure in the aorta and pulmonary trunk immediately distal to the semilunar valves. Now, afterload opposes the opening of the valves and therefore limits stroke volume. Hypertension therefore includes afterload and opposes the ventricular ejection. Anything that impedes atrial circulation also increases afterload. As such, scar tissue from some lung diseases. Increased afterload in the pulmonary trunk, it causes the right ventricle to work harder, and it gets larger. Now, hypertrophy can eventually cause the ventricles to weaken and fail. Now, the right ventricle failure is called core